the simplest but also the most important part of thoracic radiology, which is interpretation of a chest radiograph. We've divided this talk into two parts. The part one will cover more of normal and how to proceed on reading a chest radiograph, while the second will explain you more details about interpretation specifically. As I already said, that if you see any busy radiology department the world over, a chest X-ray will definitely be the most commonly performed radiological investigations across all modalities, including ultrasound. A chest radiograph is most certainly the most commonly performed radiology investigation, whether it is the emergency, the wards or the OPD, everyone needs to interpret a chest radiograph. Now, what are the views we would like to take? The standard view, as it is called, is the frontal view. The rest would get labeled as supplementary or ancillary views. However, in several parts of the world, a lateral chest radiograph is counted as part of the standard view. As we know, a frontal radiograph is performed in a postero-anterior projection with the patient standing or sitting and facing the film, or today as we call it, the detector. So, that is referred to as the image receptor. This is what a classical PA or posterior anterior chest radiograph would look like, with the patient in deep inspiration and, as I said, standing position. What are the supplementary views? Lateral view being the most commonly performed after the frontal, and the other views amongst them, let me just enlist the views which we do use nowadays and we don't. So, the decubitus is almost never used because it has been completely taken over by ultrasound. We occasionally do use the expiratory view, like in children coming with suspected foreign bodies to look for air trapping. Lordotic or epicogram is also seldom used today, as is the penetrated view. So, effectively we are only left with lateral views and lordotic views as the other supplementary views. If we look at the lateral view, which lateral to perform? How is a lateral labeled? So, the left lateral means the left side of the patient touches the image receptor now, and vice versa for the right. So, we will choose which side will touch the image receptor depending on which side the abnormality is. And if you cannot make out which side the abnormality is, or it is in a mediastinal lesion, the default lateral, as it is called, is the left lateral. And why is left lateral the default lateral view? Because a large part of the left lung gets covered by the heart. So, you do want to see that retrocardiac area. So, in default you would choose to do a left lateral view. A lateral view helps you basically see in the lung the retrosternal and the retrocardiac areas, which you cannot appreciate obviously on a frontal view. It is good for confirming the findings of the diaphragm also. The AP view, nobody likes to interpret an AP view because it is difficult to interpret, but you are stuck with AP views because obviously seldom are sick patients able to cooperate for a sitting or standing full inspiration views. So, essentially antero-posterior views are performed in wards, ICU and in pediatric patients. So, perforce we do need to get used to looking at AP views, especially several of them may not be of very good quality also. This is a lordotic view. It is also called the epicogram. If we want, it used to be used to look at the middle lobe and the apices. If we want to look at the middle lobe, we would just keep the centering of the film a little lower, and for an epicogram a higher, but essentially the projection of the direction of the ray is the same in a lordotic and epicogram. As you can see, the clavicles in this radiograph, in this view, are completely thrown off the lung fields and clears the apices. So, if you have a lesion, typically say in tuberculosis, which is hidden behind the clavicle, you would want to do an epicogram. Now we proceed on how to read a chest radiograph. It may sound very simplistic, but it is important to first confirm whom this chest radiograph belongs to, the date, match the patient ID, and also the side, the left and the right. So usually every radiographer would have labeled the side on the film, and you have to follow that labeling. So if you are confused in a patient of dextrocardia, you have to go by whatever the radiographer has labeled, because they would have labeled it correctly. So this, before you commence, it is important to identify each time the radiograph. Then the quality of the chest radiograph, if it's adequate. Some of the criteria for determining the quality we will see as we go along. Then broadly you have decided, is it normal or is it abnormal? Once it is abnormal, of course, what is the abnormality? So in part 2 we will discuss what are the correct words to use to say what is the abnormality. After what is the abnormality is solved, then we need to say where is the abnormality. So once you have the what and the where, then combined with the clinical story the patient has come to you with, you should be able to reach a reasonable diagnosis. Now the quality criteria. The first thing is rotation. So it's not just an academic point to see that whether the medial ends of the clavicles are equidistant from the spinous process or not. It's because rotation can lead to a lot of misinterpretation of findings. For example, if one lung looks more lucent than the other, that can all be a result of rotation. Or if you see apparent mediastinal widening, it can be the result of rotation, and that is why important to ascertain the quality. In terms of penetration, behind the heart, we should be able to make out, just barely be able to make out the intervertebral discs. The spaces should just be visible. If you can see more of them, it's penetrated too much, so you are losing the lung detail. In inspiration, depends in young people, this posterior end of the rib goes up to about 10th rib, but typically 8th to 9th rib, while the anterior end, as you can see, the anterior end slopes downwards and anteriorly in a PA radiograph. So the anterior end number will be less. So you can see only till about the 6th rib end. Anything in excess of 9 posterior ribs is labeled as hyperinflation, but we will discuss as we go along further criteria for when do we call it hyperinflated. Now we turn to our major work, which is interpretation. In radiology they say the easiest way to miss a finding is to find a finding, which is that you saw something on a chest radiograph and you got excited that I have made my diagnosis, and you missed something else that was happening. So it's good if you can make spot diagnosis, but what is important is to proceed in a step-by-step manner. So it's, people say you go either from outside to inside or inside to outside. Broadly, today is a time for having structured reporting formats. It's best to have everything written on a piece of paper like a checklist, and see that I need to check this, and tick it off. So it's good you write what your abnormality is, you say where it is, but you check everything else also on that checklist and keep putting a tick against it. Do not forget when you are looking that suppose you have an abnormality which is in the upper zones of the lung or the upper mediastinum, you're always looking at the neck also. And vice versa, when you are in the lower part of the abdomen, if the detail of the diaphragm has gone or you get abnormalities in the lower mediastinum or lung, always remember the abdomen. So look for the stomach bubble, look for the soft tissues and trachea in the neck also to when you are in the relevant areas in the chest. Now we come to what do we call the hidden areas. There are certain hidden areas in the frontal radiograph. For some of those, we do the lateral radiographs. So as I already mentioned to you, the area behind the clavicles, the apices, for which we used to do an apicogram, and you still can. It's a very useful supplementary view. The hilar, the retrocardiac location. See, the lung in the posterior costophrenic angle is extending behind the diaphragm also. So do not forget the retrodiaphragmatic area and the peripheral lung margins. So these are referred to as the hidden areas of on the chest radiograph, which have to be specifically looked for. Several times, why is it important actually, besides an exam point of view, to say whether it's a PA or a AP radiograph? For instance, if you don't see the stomach bubble, it's possible that it was done supine, so the air in the stomach bubble is not cranial enough to be seen. Also, when you're interpreting pleural effusion, you're interpreting pneumothorax, you do want to know whether the radiograph has been taken in a standing position or a lying down AP position. So these are some of the differentiating points which we will see on the relevant radiographs also. I have marked these for you if you look at the position of the clavicles. So in a PA, you are familiar to what the clavicles will look like. In an AP, they tend to get thrown off the field. While it's good the clavicles got thrown off, but because in a sitting or a lying down position, the patient is not able to rotate the scapula that much, the scapula tends to overlap the lung fields more. Then we come to the ribs. I drew the line to show you in the PA that how the anterior end, we are mapping the anterior end of the rib. The anterior end of the rib is sloping downwards, while in an AP view, it is more horizontally oriented. Also, as I told you in the quality criteria, that the IV disc spaces should barely be visible. In an AP radiograph, they are more clearly visible. And there is of course that issue of apparent magnification of the cardiac shadow, but as I will again reiterate in the end, we are not doing a normal cardiac radiograph in this talk. Now we come to the normal anatomy. So we follow the checklist. We are going to cover the entire checklist so that you know whether your structure is normal or not. Trachea by and large should appear absolutely dark or black, which means without anything white or a filling defect inside it. Marked for you are the left and the right main bronchi to show you the more horizontal orientation of the left main bronchus, which will get lifted up if you have any nodes in the subcarinal lesion or enlargement of the left atrial appendage. And the more vertical straight looking bronchus is the right sided bronchus. You may think that again, is it a very simplistic thing to repeat? You can see the right and left, but no, especially when you are seeing younger patient and the children and there is situs inversus, it's our job to say which is the morphological left bronchus and the morphological right bronchus. So the appearance and direction of the bronchi is important to label them as left or right. There are measurement criteria for the normal tracheal lumen, both on a frontal and a lateral radiograph. The frontal, which means the coronal measurement diameter, is marked for you and is slightly different in the male and female, being a little larger in the male. The other important structure which is seen in relation to the trachea is also marked by the arrow, which is referred to as the right paratracheal line or stripe. It's just a thin white line which runs up from the level of azygos to brachiocephalic. Essentially important for us because if this is enlarged and it becomes convex instead of being flat like this, it indicates presence of mediastinal widening, most commonly by nodes. We will be seeing examples of these subsequently. So we did the trachea, now we come to the lung. Lung, is always used like the two lungs are like an internal control. you compare the density and the volume of the lung with the opposite side. Anything which is asymmetric, white or black, which is opaque or lucent, is abnormal. Yeah? So, retrocardiac area, we have already spoken about it, and you may want to do a lateral radiograph. How do you suspect at all that something is happening in a retrocardiac area? So, if you see behind the heart also, it's not of course as black as the rest of the lung, but there's a clear cut lucency compared to the spine. So, if there is an abrupt change in this density, it looks whiter than this over a focal area, you suspect that there is an abnormality in the lower lobe which is behind the retrocardiac area, especially if you cannot make out the definition of the diaphragm beneath it, then certainly there is a lower lobe abnormality. Now, how to interpret the lung on a lateral radiograph? Important is you run your eye down the dorsal spine. As you come down the dorsal spine, what do you see? The density becomes blacker. Yeah? So, the density is decreasing as we are traveling down. If there is a lower lobe disease, this decrease will not happen or an increase will happen. Density in the immediate retrosternal area, if you see, is more black and is very similar to the density you are seeing immediately behind the LV, that is above the diaphragm. So, both areas look fairly black, the retrosternal and the retroventricular. So, these are the normal densities on a lateral radiograph, and any disruption of these suggests the lung pathology. I already said we are comparing the two sides. After we have seen where the abnormality is, then we come to division. As you know that anatomically the lung is divided by the major fissure and the minor fissure on the right side. There may be accessory fissures also, but a lot of times on the radiograph it's difficult for you to say exactly which lobe it is. In case you are not able to localize the lobes, or it's a diffuse disease, like you want to say it's upper zone dominant disease or lower zone dominant disease. So, what is meant by this terminology? Zones. In zones is not an anatomic division, it's a description which is uniformly used so that everybody understands what you are saying, and the cutoff here is the anterior end of the rib. So, you draw a horizontal line, has been drawn symmetrically on both sides view, which shows the second rib level. Above that, upper zone. Line number 2 is horizontally drawn from anterior end of fourth rib. So, it's above upper, between the two lines mid, and beneath that the lower zones. But actually you are very happy if you can actually tell which lobe it is. So, the oblique fissure is not directly visualized on a frontal radiograph, but I tried to make with some convexity a little more, but to show you how the fissure projects when a frontal radiograph is taken. This is to say, in case you have a loculated fluid or a pathology adjoining the fissure, it will outline the fissure, but the normal fissure will not be seen as a white line. So, this is the two areas that the oblique fissure overlies a frontal radiograph is one at the D4 level where it is just taking off, and then lower down as it turns medially towards the hilum are the two areas where oblique fissure overlaps. The minor fissure extends from the right hilum to about the sixth rib in the mid axillary line, and many times you may be able to perceive a very thin white line which represents the minor fissure. When you do a lateral radiograph, you can obviously localize the lobes, and this is one situation where you may want to do a lateral radiograph. If you may ask, in today's time of CT scan, what is the use of supplementary views? So, I would say whenever you are not going in for a radiograph, you're not going in for a further CT scan, do a lateral radiograph. For instance, you have an upper lobe consolidation, maybe you want to do a BAL and you want to see that, what is the organism, you want to know quickly is it upper lobe or middle lobe. You don't want to do a CT scan simply to be able to localize the pathology. It's good to add on a lateral radiograph. With very little radiation, you will get more exact localization. And the situation on the right and left side is different because of the minor fissure, but if you combine right upper lobe, right middle lobe, then the volume becomes similar to the left upper lobe. Also to be noted is the slope of the oblique fissure on the two sides is a little different. You will be often asked in the exam if you can see both the fissures, that which one is the right and which one is the left. So the left one has a more vertical course because it ends at the posterior cardiac border, but the right one goes right anteriorly up to the costophrenic angle. So the anterior and more horizontal one will be the right one, while the more vertical one which stops behind the heart border will be the left one. The relevance of it will become obvious to you as we see the cases subsequently. Let's map them on a frontal radiograph. So pardon my drawing, but we tried to see this is what the right upper lobe, this is the amount of space it takes up, this is the right lower lobe, and then adjoining the paracardiac region is the right middle lobe. Now hyla, what are hyla basically? Every organ will have a hilum. A kidney has a hilum. So here you have lungs and you have the vascular structures in the center, and this is the connection between the two, which means that vessels will go out from the heart into the lung, from the lung into the heart, bronchi will go out from mediastinum into the lungs, and the veins, nodes and some fat thrown in form the hilum. Suffice to remember that the hilum should always have a concave outside appearance, what is called a V or a Y shaped. So if it's concave outside and the point at which it forms the V or Y is often referred to as the hilar point, then these are normal. The second thing is their density. The density of the two hila should be similar, because sometimes a nodes may just appear as increase in density. Third is position. Position, left hilum is higher than the right hilum, because the left pulmonary artery, main pulmonary artery goes above the left main bronchus. So that's why the left hilum is higher than the right hilum. After you have looked at the pulmonary vessels at the hilum, although we are not covering cardiac, but roughly you need to know that what do the peripheral pulmonary vessels look like. So on a chest radiograph, it's difficult to differentiate arteries from veins. Broadly in the distribution, the upper lobe vessels, the upper zone vessels are always narrower compared to the dependent vessels. Also, we are not able to identify vessels clearly in the lateral third of the chest radiograph, because if we do identify these, then these are referred to as a sign of plethora. There are measurements also which have been given for the vessels. If you think that they are enlarged, you can see, so if the vessel measures, you compare it to its accompanying bronchus. The cutoff given is 1.5 times, so vessel more than 1.5 times bronchus. Vessel visualized in the first interspace on top and exceeding 3 mm is abnormal. Then there is a transverse measurement of the descending pulmonary artery. Marked for you is the right descending pulmonary artery. There are variations, again in male, female, but broadly 16 mm is taken as the upper limit of normal. We already discussed what is mediastinum. So you have lungs on the side, mediastinum contains the heart and it contains a lot of tubes which are passing between the neck and the abdomen. Everything traverses through the mediastinum. So besides the heart, you will have aorta, IVC, esophagus, thoracic duct, sympathetic chain, and pathologies affecting any of these can result in mediastinal masses or widening. This is one slide which I borrowed from the net, SlideShare, to show you the normal borders of the mediastinum and the heart, which you should be familiar with. So, we go from the right side below upwards. Right atrium always forms a part of the border. Ascending aorta, in young patients, ascending aorta may not contribute to the right heart border. The more it unfolds, the more it contributes to the right mediastinal border. And above that, the SVC, which eventually goes on to the right brachiocephalic vein. Sometimes the part of the azygos may be seen also as a small bulbous projection. Now we come to the left side. Let's again go from below upwards. The left ventricle or the LV on the left side. Just above the left ventricle will come the left atrium if the left atrial appendage is dilated. So, if you have mitral stenosis and the LAA bulges, it will come just above the left ventricle. Then comes the LPA, and this is referred to as the pulmonary bay. Above the pulmonary bay, bulging outside towards the left lung is the aortic arch, and between the aortic arch and the LPA is the aortopulmonary window, a very important location for nodes from our point of view, because subtle nodes coming in tuberculosis or sarcoidosis may simply fill this aortopulmonary window out and you may miss the abnormality. Then you have often heard of anterior mediastinum, middle mediastinum, posterior mediastinum. What are these compartments? Essentially, from an anatomy point of view, there are no compartments. In the lung, we had fissure, but in the mediastinum, there are no fascial planes. The compartments are simply for descriptive purpose. There are two methods that people use. One is the way the anatomist described it, and several people will use this method, which is anterior, middle, posterior. The heart is middle, everything anterior is anterior and posterior is posterior, and you draw a line between the manubrium and body of the sternum, one point, and D4 D5 intervertebral disc, the second point, that cuts off the superior and inferior. Those of you who follow the Felson's textbook or are familiar with the Felson's method, this is a little different, because Felson's method places the heart into the anterior mediastinum. So, herein also two lines are drawn, but the first line runs from the border of trachea to behind the heart, and line number 2 is drawn 1 centimeter behind the anterior margins of the vertebrae. And then again anterior, middle and posterior is divided accordingly. Essentially, the difference between the two models being that where do you place the heart, and in Felson's model, posterior mediastinum essentially has only paravertebral pathology. Now, what are the criteria for mediastinal shift? Roughly to say, you would have heard that 1/3 of the heart lies to the right and 2/3 right to the left, but it is actually variable, and even 1/5 to half of the heart can lie on the right side. But broadly, if there is a shift of the mediastinum along with the shift of the cardiac shadow, you will label it as a mediastinal shift. So, this is the proportion of 1/3, 2/3 for rough, which I mentioned to you. We next come to the diaphragms. Diaphragms, as I told you, they are dividing thorax from the abdomen. Both types of pathologies can affect it, lung lesions in the lower lobe, pleural lesions, subdiaphragmatic lesions. So, important to know the normal position of the diaphragm. So, the right diaphragm is higher than the left by about 1.5 to 2 centimeters, not an absolute rule. As I have shown you that it can be at the same level, it can be higher than the left side, but in majority of the people the right diaphragm is higher. And why is that so? That's because of the pulsation of the LV, which tends to keep the left diaphragm down. So that is the developmental reason the left diaphragm is down. The CP angles, we have two angles here, the costophrenic and the cardiophrenic. So when we refer to the term CP angles, we are talking about the costophrenic angles. Cardiophrenic is referred to as the cardiophrenic angle, and the costophrenic angles are very sharp and acute because this is the first place, as you are aware, where the pleural fluid accumulates. This is what we call the height of the diaphragm. To see whether the contour of the diaphragm is normal, we draw a line from the costophrenic to the cardiophrenic angle. After we draw this line, we drop a perpendicular. We drop a perpendicular from this line to the highest point of the diaphragm, and if this convexity gets lost, then we label it as flattening. We will be seeing it in more detail subsequently. The second short line to show you the difference in the heights of the two diaphragms. So why do we measure this height? Because less than 1.5 centimeters of this height is labeled as the flattening of the diaphragm. Also, if you see that this peak point of the diaphragm is at about the 1/3, 2/3 cutoff of the diaphragm, because anything lateral than this is referred to as a lateral peaking, happens in subpulmonic effusions. We have finished broadly with the normal, and I will be doing the morphological patterns in part 2, but part 1 we continue to cover localization of lesions. As I said, once you have identified that there is an abnormality, you want to locate where it is. What do you want to locate? You want to locate, is it in the lung, is it in the mediastinum, or is it in the pleura? You want to locate, is it a thoracic lesion, or it could even be a cervical or abdominal lesion. You also, once you decide it's in the lung, then you want to know which lobe. If you decide it's in the mediastinum, you want to know which compartment. And if you see a mass which is in the hilum, you want to know essentially, is it vascular or is it a non-vascular mass. So we will now see criteria for making each of these differentiations. Parenchymal lesions. The simplest way, if something is going to be located in the lateral end, you obviously know it's not in the mediastinum, what is referred to as epicenter of the lesion. So this is a parenchymal lesion. So if the epicenter of the lesion is in the lung, it has, the margins don't really help you because it can be well defined or ill defined, but if an opacity or mass is completely intraparenchymal, all its borders will be seen, all the borders will be seen, and by the angle sign they will form acute angles with the rest of the surrounding lung parenchyma. This is a cavity with an air fluid level. If it were in consolidation, you would see air bronchogram. We will see examples of these in the subsequent slides. And if you do a lateral radiograph, this round lesion will continue to appear round. Unlike, we'll tell you unlike what. So then we come to mediastinal mass. First, epicenter, of course, epicenter in the center, not laterally, in the center. Margins, here the margins help you. Mediastinal masses will have sharp margins because their interface with the alveoli is not lost. Yeah, they are not. In the case of the lung, the surrounding lung may have consolidation, so there may not be a sharp wall or a border, but in case of mediastinum, there is a sharp wall or border. Then using the angle sign, therein we said it forms acute angle with the surrounding lung parenchyma. So here it forms obtuse angles with the rest of the mediastinum, upper border, lower border. If you draw the angle with the normal mediastinum, it's an obtuse angle. So this is the angle sign. A mediastinal mass can also present simply as widening of the mediastinum. Here you need to see the paratracheal stripe got widened, the aortopulmonary window got filled up. Not only that, I can't make out the aortic knuckle also. So there is a mediastinal widening. Often I am asked, what are the criteria for saying mediastinal widening? You will come across a criteria of 8 centimeter or more than 25% of the transverse width of the chest. But actually, this criteria is not described in context of masses. It has been described in the context of thoracic trauma as to when to suspect a mediastinal hematoma. But broadly, yes, this is the criteria, or as I said, you know your normal borders, you know the normal empty spaces, and if they fill out and this border becomes convex laterally, there is a mediastinal widening. So we can have a mediastinal mass-like lesion or simply mediastinal widening. Then chest wall and pleural, what are combined labeled as extraparenchymal lesions versus a parenchymal lesion. If the lesion is located along the chest wall, we will see examples of everything. Then how the angle sign will change. The problem is sometimes a pleural lesion can be located in the middle of the lung. So the epicenter doesn't help you much, the angle sign doesn't help you much. Then there are other signs which we can see. Another useful thing is do a lateral radiograph. What did I tell you in the lung parenchyma? It remains round like that. But if it's a pleural lesion, it will not remain round, it will extend anterior to posterior. The dimension changes. So if you do two radiographs and the dimension changes, then the lesion is not in the parenchyma, it is extraparenchymal. So for instance, as I said, on the right is a very large lesion. I cannot tell whether it came from the lung, it came from the pleura, it came from the chest wall, it came from the diaphragm. Then how will I decide? So one thing is it has a very sharp superior border. From the sharp superior border, I think that the lesion is less likely to be in the lung parenchyma. Also, I don't see any speck of air inside it. I don't see an air bronchogram. I don't see any cavitation at all inside it. Then do you think this is just a pleural lesion or is it a chest wall lesion? I will look at the ribs. What will happen in a chest wall lesion? In a pleural lesion, the ribs may or may not get destroyed, but in a chest wall lesion, almost inevitably I will see some chest wall changes, which is not to say that the lung lesion cannot destroy a rib, but relative points. Then after we have decided that it's more likely to be extraparenchymal in the chest wall versus pleura, I told you if I see a single rib destruction suggestive of a mass, osteomyelitis, then there is no part of this mass which is bulging in the lateral chest wall. The muscles of the lateral chest wall are looking absolutely neat and clean. So I'm most likely dealing with a pleural effusion or a pleural mass. And what should I do next? I should do an ultrasound next. So that is how it helps, because it helps you to suggest the next modality. The next modality can be an ultrasound, it can be a lateral radiograph,